Good afternoon. Are you ready to get this afternoon going? Yeah? Okay. So we'll have a couple more sessions in here this afternoon, or I guess a couple more sessions where we're split out. And then at 3 o'clock, everybody will be joining back over in the Howard Ballroom to be back together again. This afternoon, we have a talk by Dr. Ling Len. It is called Counseling Mary Jane. If anybody can guess what they think this may be about, that is not a patient's name. So, Dr. Len is a diabetologist at ANTHC Diabetes Clinic, and she's a hospitalist at the Alaska Native Medical Center since 2018. She finished her internal medicine residency in San Jose, California, and completed University of Washington's Global and Rural Health Fellowship in Alaska and Nepal, focusing on cardiovascular health. In addition to providing multidisciplinary diabetes care with her team, Dr. Lin is also certified in obesity medicine from the American Board of Obesity Medicine. She enjoys learning from patients all over Alaska and traveling to field clinics in the regions. Here is Dr. Lin.
Hello. I realized there was no description of what the talk was going to be. So it's open to interpretation. And we will be learning together. So really, this is a case of Mary Jane. And so there's Mary Jane presenting at the emergency room, 29-year-old female with type 1 diabetes, nausea and vomiting, and abdominal pain. What are we thinking? It's going to be kind of interactive. You can speak up. Nausea, vomiting, 29-year-old female with type 1 diabetes. Hyperemesis. Yeah, DKA. So a little bit more information. She was diagnosed when she was 17 years old in 2013. She does have this suspected diabetic gastroparesis history. We'll kind of talk a little bit about that. She says she's been vomiting for 2 to 3 days, no blood. It's more of clear and like dry heaving. She has pain just everywhere. It doesn't really travel up or down. It's just kind of everywhere. Really no diarrhea and really not too much bowel movement. No family or friends having similar symptoms. She drinks alcohol sometimes. Last drink was over a month ago. She does use marijuana 2 to 3 times daily. She's visiting Anchorage. She's from the village. She's using a little bit more while in town and really denies, other street drug use. What other informations would you want to know? Lab work? Any other social? Is she pregnant? Good question. She's definitely in that age range. Yeah. And she just start GLP-1 agonist? Very true. We use GLP-1 now off-label for type 1 diabetes as well. Good thinking. We talked a lot about incretin earlier today. How much is she smoking when she smokes marijuana? Is she using concentrated form of marijuana? Yes. Good questions. Is she vaping? Yeah. So really a lot of it, even before the labs, we can get from just social history. She's not sure how potent is the marijuana that she's smoking. Again, she's visiting friends, provided the products, and she has not recently started on other new medications, really, and kind of her medication history, right? Like she's on glargine, her basal insulin, she's on MDI, basal insulin, glargine 20 units, and she's on aspart as needed for food and correction for carbs. And really the other part is compliance, right? Thinking about DKA. right? Does she have her meds and she's visiting? Did she run out of meds, right? When was her last shot of insulin is oftentimes a good question as well. And I will then now kind of tell you what this talk will be about. It really is that question about hyperemesis syndrome versus DKA in specifically type 1 diabetes. And why did this come up? Mainly because we had several cases in our clinic, but at the same time, it's actually in the ADA 2025 guideline. It's one of the new things that is there, and we kind of just want to talk about it. And most of my references are from the ADA guideline with our studies. So this is, just make sure I didn't miss any. And so this is her labs, her VBG. We don't do as much ABG, but her VBG, the pH 7.46, kind of more alkalotic rather than acidotic. Her beta hydroxybutyrate is elevated, 3.49. Her lactic acid is not horrible. Her glucose was 298. She does endorse actually taking her basal insulin the last few days. She hasn't really been eating. She's worried about low, so she really didn't, dose her aspart, her short-acting insulin, unless it was over 300. Her A1C is elevated at 10.7. However, right now we probably don't worry as much immediately in the emergency room. Her alcohol level is actually less than 10. But the other part is that she could be withdrawing if she is a binge drinker, alcohol use withdrawal. They can present with nausea, vomiting as well. So that could be part of the differential diagnosis as well, alcohol withdrawal. And her UTOX actually is negative for other substances as well. And so, of course, usually they come to the emergency room, they get fluids, and then everybody sees like type 1, they immediately think about DKA, despite the pH is actually not specifically acidotic. And the other part I do want to mention here is the bicarb is 20, which is not low, or it's on the lower end of normal, but not technically very low. And so given her history, kind of looking back, she had prior admissions 3 months ago for also kind of this like cyclical hyperemesis, nausea, vomiting, cannabis hyperemesis syndrome was suspected. However, and there's like, maybe she's been living with diabetes for a while. Perhaps she has diabetic gastroparesis. So she did go, unfortunately, we don't have the study readily available at ANMC. So, she had to go outside to regional hospital to have that imaging done. Unfortunately, they only did a 2-hour study. She last admission did get a GI consult, and they really recommend more of a 4-hour study instead of only the 2-hour. Even though I put just the report for 2 hours, she had marked depressed gastric emptying. And again, I'm not gastroenterologist, so I was just kind of putting what their recommendation was. And of course, really, you want to rule out all the other stuff, right? This is cyclical vomiting syndrome for her, and that endoscopy, an abdominal ultrasound would be something to consider. Her abdominal ultrasound was normal. She was scheduled for a follow-up EGD at a GI clinic. Unfortunately, she didn't show up. And at the same time, with the gastric emptying study that was done, it was kind of unclear if marijuana was involved prior to her going to get that study done, right? So not just cannabis, but marijuana can delay gastric emptying, in addition to really hyperglycemia, poor control of her diabetes. And so the GI recommendation last submission was, you can try, diabetic gastroparesis treatment, such as Reglan, domperidone, or I don't know if you guys have seen people here with really bad gastroparesis that they actually have a gastric stimulator, like a pacer for their gut. So when I was in training in California, I actually had a couple patients on that. I didn't know that existed, but that could be implanted for really, really bad case of gastroparesis for any reason, not just specific diabetic, but that's the most common origin of indication for that. And so we want to kind of bring into light, ta-da, in 2025, 5.42. It's actually a recommendation now, grade C, given kind of the level of evidence. It is we would advise type 1 diabetes, patients living with type 1 diabetes not to actually use recreational cannabis because they do have increased risk of diabetic ketoacidosis. And then we kind of just want to look into this a little bit more because, again, this case presented several years ago now when I first started in the clinic. And this just came out. I double checked 2024, 2023. It was not there. And this is relatively new. And so really diagnostic criteria for cannabis hyperemesis syndrome, specifically someone with type 1, again, oftentimes type 1 patients with type 1 diabetes presenting the ER with ketone positive, people immediately think DKA, right? Diabetic ketoacidosis. But it's important to really ask if there's any substance use or recreational marijuana use. And really oftentimes you should start, thinking about this when their pH really is not that acidotic, when their bicarb is actually more on the normal side, more the lower ends of normal, and with ketosis, that part is the same with DKA. Oops, sorry. And so a little bit more about cannabis hyperemesis syndrome, really episodic, cyclical, nausea, vomiting with use of cannabis is, and then really the other part of the criteria is like it goes away when you stop using marijuana. Okay. And so overall, again, just from my research with the GI literature, cyclic vomiting syndrome, there are actually a bunch of different ones out there. Cannabis is CHS is not the only one. It's really a gut-brain axis dysregulation. And so functional dyspepsia, irritable bowel syndrome is another one of those that, you would kind of think of, and psychological and visceral hypersensitivity, and really gastric emptying issues. And so those are kind of, and especially in younger patients living with type 1 diabetes, likely when they present, those are really in possible differentials to consider. And really, you really need to rule out everything else before you can hang your hat on one diagnosis, other than, I guess, if they stop using marijuana and that goes away, it's probably quite telling that this could be what it is. So a little bit more, this is just general public, not specifically with type 1 diabetes, that they actually have done a retrospective study showing states that with legalized recreational cannabis, they have more cases of cannabis hyperemesis syndrome presentation in the emergency rooms over the years. And as more states legalize their marijuana use, we start seeing this more and more often. It was interesting to kind of see the first mentioning and kind of like summarize of like a relation of the syndrome, cannabis related kind of cyclic vomiting syndrome was not too long ago, in the early 2000s, like 2001, 2002, but again, maybe the use has been different and legalization has changed. And so I definitely went into like my research, like, why is this happening? And really cannabis, so there's THC, the tetrahydrocannabinol, and CBD, the cannabidiol. They really work on the synapse of the nerves. So where the nerve and nerve junction is, and it binds to different receptors specifically that really have the kind of psychoactive effect. So people call it get high versus the anxiolytic effect, and the different compounds does different things. And so now as you may or may not know, I didn't, how a lot of the product, they actually select THC or they select CBD. Not everybody used the original form of the plant that has both THC and CBD anymore. And so, yes, concentration of the product that they're using is important. And for the patient that presented in the ER, she had no idea. She just came into town. Friends have her try some. She had no idea what's in it. Or like maybe it has something else. The other time when I was inpatient, like someone was trying recreational drug from friend and it had fentanyl in it and she didn't know. She came in like zonked out, So when you get stuff from friends, and that's why Utox was checked just in case if there were other things that was in the substance that was used. And so we'll talk a little bit more into that, but I just kind of want to mention really where does it work? And so nerve is everywhere. So it's not just in the brain, it's actually on the skin, it's in the gut, and it triggers the vagal response. And that's kind of where the nausea also happens, not just from the brain. So management specifically for cannabis hyperemesis syndrome, the other telltale sign, so I learned, is that it get relieved by hot shower. Again, that nerve synapse is actually under the skin as well. And so by actually kind of mechanically by temperature, open up kind of that synapse and such, it kind of relieve the symptoms. Acute treatment, of course, other antiemetics and dopamine antagonists specifically has shown beneficial. A lot of haloperidol and now more droperidol seems to be more effective than other ones such as Zofran, Reglan. And then the other one that is quite unique for cannabis hyperemesis syndrome is capsaicin cream. So again, it's on the skin, and that actually targets one of the similar channels that is on the nerve, and then help kind of open up and redirect the neurotransmitters and reduce the symptoms, which I did not know. Next time I will try that on my patient in the ER. And of course, the symptoms will be resolved with cessation of cannabis use. Unfortunately, precise duration of cessation of cannabis is unknown to lead to resolving of the symptoms. Most of the time it's within days. Most people get admitted, they are not using, you hydrate them, you supportive care, and then they feel better. Most of the time they leave AMA and then they may get readmitted later. But it really has various data or more of a self-report ranging from days to months and even 2 years. What is interesting that I also learned is that cannabis, specifically THC, is actually stored in the fat in the adipose tissue. And so sometimes people may have not used cannabis in a long, long time, but they start losing weight or they are fasting, they have like adipose breakdown, and you get a little bit of THC like leaked in. And then you might get high again, I guess. I don't know. But it's kind of interesting as I was kind of doing more research on this because they have really long half-life. And sometimes it does depend on if you're having adipolysis. You might have a little bit of effect even if you used it a while ago, perhaps more like days, 2 weeks, probably not like you used it a year ago and you still have it. I don't think that was kind of the way the paper was describing that. And I do want to talk a little bit about what is DKA, what is diabetic ketoacidosis. It is also nausea, vomiting, abdominal pain. You have got hyperglycemia, which, the lady had about 298, I think was the glucose initially on presentation. Just high for type 1, but, not like outrageous. But ketonemia, what is more different here is the non-GAP metabolic acidosis for DKA specifically. And the same patient, I would say I think this was about maybe 6 months, 3 to 6 months after her prior presentation. She came from a village, she was medevac over. She was actually altered this time, encephalopathic, only alert oriented times 1. She ran out of insulin for over 24 hours. She initially went to the clinic because she was not feeling well. They told her to stay and try to medevac her. She left AMA, continued to nausea, vomiting. She came back in again with a pH of 6.9, and that is low, very low. Her blood sugar was significantly higher at that time. In the village, they can only do a urine, like quick POC labs. Her ketone was positive. She got some regular insulin. Luckily, most of the village clinic has some regular insulin, even if they don't have other insulins. And all they could do was giving her lots of fluid until they can medevac her out. So at outside hospital lab, I don't know why they always check A1C in this acute situation, but it is 12 now instead of 10. She was not pregnant. Sorry, the first time she presented ER, she was also not pregnant. Her creatinine was elevated. She was in AKI this time. Her beta hydroxybutyrate again is elevated, right? However, she was significantly more acidotic this time. What is also interesting here, unfortunately, in the village clinic, they couldn't check the bicarb, but the bicarb, once even she landed in ANTHC ER, her bicarb was only 6, which is very, very low, single digit. And that would be, I would say, a big differentiation. Again, very significant metabolic acidosis compared to the cannabis hyperemesis related, because oftentimes people do have a little bit more alkalosis from the vomiting prior. As you may now realizing is that cannabis hyperemesis syndrome, the marijuana is causing the nausea, vomiting, and then they go into ketosis. Versus DKA, you have the hyperglycemia for whatever reason. They could be sick, they could, have an infection or whatnot, or ran out of insulin. The hyperglycemia then leading them into the nausea, vomiting. So that's a big difference. So oftentimes you don't see as much of the metabolic alkalosis from vomiting up the acid as often. It can definitely be mixed picture. Again, with her story, she needs to be ruled out for everything else, right? Her gastroparesis from diabetes versus other medications, or she could have other autoimmune disease, right? She is prone to have other autoimmune disease given her history of type 1 diabetes. And so this time it was a little bit different. She was admitted to ICU. So the first time that was also a big difference. She was just admitted to the floor. She was able to recover quite quickly with sub-Q insulin the first time. This time she required insulin drip for a few days. She finally woke up. She was more alert. She was obviously a lot sicker this time around. She was still smoking marijuana, really stopped using alcohol. I guess the story didn't add up because she said she stopped 1.5 years ago, but it's just about 6 months ago. She said it was a month ago. Anyhow, patient report. However, this time she did run out of insulin. There was an issue with, getting her refills, and she couldn't dose for about 2 to 3 days when she presented in the village. And just a little bit, DKA, there's mild, moderate, severe. A lot of times we kind of do it by symptoms, as you can see on the very the bottom horizontal thing. Really, she was quite actually altered, but when she came in this time, and so she was quite severe. But it would be kind of varies by presentation. But in general, they're acidotic. They have ketosis, and they have a metabolic anion gap. So now, let's go back to what does marijuana do? And so as you can see here, the THC really targets the CB2 and CP1 receptors. They have that psychoactive effect in addition to many other things. And the CBD is a little bit newer studies. I feel like studies older are mainly focusing on the THC. Now there are more and more studies coming out with CBD. They are leaning towards the CBD now because it has less of that psychoactive effect, less of the hallucination and such for medical use, right? Because you don't want to get people treat their medical problem, and they are so confused. And again, a lot of these are still kind of in the molecular level. There are a few medical indications for marijuana already, but we'll kind of go over that. But mainly THC, this is kind of what people in humans. So they have studied a lot of this in rats. But in human, this is kind of what people report, like lightheadedness, euphoria, loss of concentration. So there is this question about like increased anxiety versus actually reduction in anxiety feeling. And so it seems to be dose dependent. And so there's also a big difference if you inhale it or if you eat it. So if it goes through the liver, right? So the liver process it, it's more potent. So as you can see, the onset, over time in hours, it's a little bit delayed, but it's still quite potent. You need a little bit less actually, technically. So these, the green is a lower dose, medium dose, and the red is high dose. And so if you inhale it, it bypasses the liver. So it kind of goes directly into the bloodstream and into your synapse. And you have the effect immediately. And again, it's also, as you can see, it's dose dependent, right? When you're kind of with a high dose, you really hit these kind of toxic. I don't really know what green out means. But apparently it's when you're sweaty, nauseated, heart palpitation, paranoid. With marijuana. I guess that's what it's called. And so there are some medical indications for synthetic cannabinoid. And so a lot of it, as you may know, it's actually used to treat nausea and vomiting in chemo patients in oncology, but the dose is just so different. It's so small, right? In addition, I did not know this until I started doing this research, but the CBD with a little bit of benzodiazepine is actually used together for a really difficult epilepsy syndrome, seizure disorders. And that is actually available in the market as well. And like I said, there are kind of different indications, medical conditions that marijuana, THC, and CBD both are being studied for. Outside of the United States, you can actually get cannabinoid products for multiple sclerosis pain. Again, most of these are kind of more in the pain research. It reduces pain is also a syndrome, how one interprets the nociceptors and such. And so marijuana has kind of shown being able to interfere or disrupt other pathways other than the opioid alone to block the nociception, I guess, stimulation. And so CBD now is actually being studied for as a detox and rehab kind of supplement medication because it has shown to normalize the amygdala, which is a reward center, and decrease cravings and motivate like trying to use. And also there's that kind of reduction in anxiety, antidepressant effect more through the serotonin. So we have a lot of mood medications that is through the serotonin pathway. It's also being studied as a sleep aid. But again, a lot of these are just dose dependent. In addition, and so CB, the serotonin pathways really is in brain, in the gut, in the kidneys, in the muscles, and like I said, in your skin. It's really kind of everywhere. However, they're still trying to learn more of the side effect at different doses, right? A lot of the studies are now still in mice, just because they can simulate those medical conditions. And so human trials are a little bit less, and most of the human stuff studies are reporting, right? Patient reporting with surveys and such for the most part. But I do think they have been doing a lot of functional MRI for the brain to kind of see where perhaps the receptors are being triggered, where the activity is in the brain for more of the mood and pain management. And so kind of just bring this back to not just marijuana use, but also with patients living with diabetes, specifically with type 1. It is now we should highly recommend that our patients not to use recreational marijuana if possible, unless they have other medical conditions. I mean, if they have cancer in a lot of pain, perhaps we would consider that. And really, studies have shown, again, a retrospective study, it increased the risk of DKA twofold. Okay. And so luckily the patient presented initially, the first case, she was not yet too acidotic. So of course it can kind of snowball into that if she just stopped taking her insulin because she's just not eating and she become insulin deficient, right? In a type 1 diabetes, then she can end up, really in truly acidotic state and become altered. And so this is more of a graph where they, again, take a look at patients with type 1 diabetes and looked at their serum their pH. And so that's why initially, if their pH is kind of towards that normal 7.35 ish higher, they are probably more likely substance use related, whereas they're truly insulin deficient DKA, they're more likely presenting in a more acidotic picture. And they actually went back, and this is a single center granted retrospective study for type 1 diabetes with, again, DKA on the chart, right? But then when they actually look at the pH and stuff, so they probably have some. And sorry, they also, the other data point was urine cannabis to kind of show that it's assumed that they were using cannabis before presentation in the ER. And so, again, these studies are small, single-centered. They were able to kind of find the prevalence of cannabis use with type 1 diabetes in young adults was about 30%. In addition, and I think this is where a lot of the ADA recommendation, there are multiple studies, but this is one of in their reference is that if they used cannabis in the last 12 months, there was an association. Again, there's causation, but association of DKA compared to those with type 1 diabetes and not using cannabis. In addition, they showed, a higher A1C compared to those who are not using. However, there was no difference in severe hypoglycemia if they were using cannabis or not. And even if they adjusted for if they were wearing a pump or not, their age and their income, the overall A1C is still slightly higher for the cannabis users. And so there is definitely the thought, cannabis definitely also increase cravings in some way. It can make them have higher daily caloric intake. And that actually has shown here in the States in the ANTHC study that, again, this is not people with diabetes specifically, but 20% higher calorie intake for those who are using cannabis or marijuana, Mary Jane. And so treatment, right? So counseling, again, motivational interview and cognitive behavioral therapy. And really, as a provider, as a clinician, you need to ask. And kind of all this stuff that you guys mentioned, how often are they using? What form are they using? What's the concentration? Where are they getting it? What are they using it for, right? Are they using it just recreationally, or perhaps they truly have pain, or perhaps they have, panic attacks or whatnot, right? Or for sleep. And perhaps, finding something that works for them, or can they reduce, right, and slowly wean off? They have been small studies showing kind of other ways to reduce cravings for specifically marijuana use, not very strong, but gabapentin in adults, acetylcysteine in adolescents. And then for the withdrawal syndrome, withdrawal symptoms, to using really a lot of kind of our antidepressant, mirtazapine or quetiapine. So how do we screen patients for it? How do we know what's too much? How do we know what is too little? And so there is something actually called the QDID-R, the Cannabis Use Disorder Identification Test Revised. And it has, this has been around actually a long time, since I think early 2000s, or I'm not sure if it's into the 90s or 80s. However, it has shown, the survey has been validated, and it screens pretty sensitive, 91% sensitivity and 90% specificity for cannabis use disorder. And so that would be when they score 12 or more. And in that would be kind of something we categorize probably with dependence, really marijuana dependence use, that they just can't, because once they stop, they will withdraw heavily. Versus perhaps if you are less than 8, you're okay. I'm not sure really otherwise when it's too low, but when it's too high, I feel like this is a good tool, and really to perhaps make you more aware and try to bring them back more often for counseling, really identifying social factors, why they're using, reasons for use, and find other ways really to kind of compensate or, manage and their other stressors. And so, of course, you guys, all the educators, are probably way more knowledgeable than me with really different strategies. So with the Substance Abuse and Mental Health Service Administrations, they do have something, it's a little bit old, 2015, they probably should update it, but I do feel like the core concepts are probably still similar, really assess readiness for change. And one thing might just be they need a provider to kind of bring it up to them. Is this really impairing your daily activity? Are you no longer able to take care of your kids or pick them up from school because you are just passed out at home, or you're too tired from using or whatnot? Goal setting, and really, evaluate for skill sets to accomplish their goals. And so those you can find, actually they have a whole, I think 200 pages on their website, but that you can, or, and then maybe trigger a referral to behavioral health or counseling at the resources that is available. More about the patient. I saw her about 6 months after her prior ICU admission, the DK admission. That was when I first met her. She went to homeopathic medicine, was taking supplements. She went to Mayo Clinic, so she says, and she was prescribed Montegrity, which is a selective serotonin receptor agonist that I put on the side, prucalopride. Unfortunately, she couldn't get it because it's not on our formulary. Anyhow, supposedly it was going through purchase refer care. I couldn't find any records. I don't know who she saw at Mayo Clinic, or if she had further gastric emptying studies. But again, she, in a good way, was very a good self-advocate for herself. Her family supposedly took her to try also different modalities and clinics to try see why was she having cyclic vomiting syndromes. She did, by the time I saw her, she did stop using marijuana for 6 months, was feeling okay, but no more readmissions. And I most recently saw her about a year later. She now is a mother of a healthy baby, no more nausea, vomiting. And so, perhaps for her, it probably could have, she should have been screened for eating disorder, right? Or, and probably a lot of it is psychosocial, like her mood and stuff. And when she's in a good social situation at home, she went through a relatively healthy pregnancy. We had a lot of hard time getting her blood sugar better controlled, but she had a healthy baby boy. So it all came out to good news, but we kind of just want to bring this case to light that it's actually now in the guideline, and really we should talk to our patient about it. Any questions? Yeah. The study did not, they have a few mentions. Again, I was like in a rabbit hole looking at all these things. They mentioned on the arms and legs, but I don't know, maybe some other people did it on the abdomen. Again, these studies are so small. But they really hypothesized due to the receptor, the capsaicin also work on the TRV1, that is very similar to the CB1 and 2. Mhm.
I was just curious on the Colorado study or any of those other studies, did they like look for diabetes self-management, like motivation or missed boluses, stuff like that?
No, it was mainly just a chart review. They looked for UTOX, they looked for diagnosis code, DKA, they looked for the labs, but nothing really social. And then, yeah. So again, even the marijuana use was by UTOX. And also the other part, the urine tox result, it can last for about 4 to 5 days. And so they may not have immediately used. But again, onset of the hyperemesis syndrome can really happen anytime.
I was just wondering, you said that she had quit for 6 months. Did she restart? And also, if she did restart, did the cyclic vomiting also come back? Just curious because we tend to have a lot of patients just like this.
Yeah, sorry, I forgot to mention. So when by the time I saw her, she was definitely, her mind is in the right place. She just no more use. And I think subsequently she had a pregnancy and such. But before, and like that's why I said when she was admitted, at least by chart review, the very first time for intractable nausea, vomiting, she was probably still intermittent using, and that's why she kept on getting readmitted for nausea and vomiting. I do want to mention, I forgot, I read so much about it, but I realized I didn't say anything at all. So at low dose of THC and CBD, it really, that's kind of where the antiemetics happens, and the CB1 and 2 and the serotonin channels really help in the brain and the gut to reduce the nausea. However, when you use it every day, and when you start using more and more, it downregulate the receptors. And that's the thought right now, is that the receptors are downregulated. So because they're just flooded by so much stimulation. And that's why the more you give it, they're not going to have that cessation of nausea, vomit. It kind of worsens. So it kind of paradoxical. Sorry, that's current the working theory.
I just had a clinical pearl to share because I've had more gastroparesis working in Anchorage than I ever had anywhere else, both in diabetics and non-diabetics. I actually have somebody on TPN because of gastroparesis. And a shout out to our integrated pharmacists at SCF and ANMC because their great olanzapine can be hugely helpful, low dose. And it's helped a couple of my patients if anybody needs a take home.
Yeah, so the one that she said was prescribed by Mayo Clinic, Montegrity, was very similar mechanism of action as sorry, not olanzapine, ondansetron, Zofran. Actually, it's a serotonin, but olanzapine would be antipsychotic. Sure. Anything else? Yes.
Is there any difference in like if somebody's just taking CBD versus THC as far as the hyperemesis problem?
Yeah, so I do believe both of those right now for hyperemesis or nausea and such is dose dependent. So it seems like a low dose, both of them, THC and CBD, could be helpful. It's mainly a high dose and possibly just chronic use. I don't know if they have actually studied chronic use at low dose, if that worsens the nausea. CBD, so I learned, is that it can actually block your CYP enzyme in the liver. And so if your patients are on medications that is processed through, which a lot of our medications are processed through that liver, it can have hypertherapeutic level. I do not know that. But again, it could also be dose dependent and how often they're using it, right? But that is something to kind of consider. Sometimes patient can be super therapeutic. Right, thank you.